Most of the health workers are not women. They are men. One thing you need to understand, statistics after statistics, especially in the northern Nigeria, is shown that majority, about 70% of the women do not deliver in the hospitals. And one of the reasons they give is because the hospitals are manned or they are attended by men when they go, and they don't want a man to attend to them when in labor. So it's very important for us to have the female health workers so that we can have majority of our women visiting the hospital. It's only through that we will be able to reduce the high rate of maternal mortality that we have in the country, and especially in the north. The mandate of Women for Health as a DFID funded program is really to increase, first of all, to increase the number of female health workers that we have. And importantly, it's not just to produce them and keep them in the urban centers, but really to take them to rural areas where, first, that is where the large population of our women resides, where we have high fertility also in rural areas. It is more than possible to increase the quantity and the quality of the female health workers. We've done it and it's very successful. We use 8 key approaches. When we started, the government doesn't consider the health training institution as one important aspect of the health sector. From the beginning, we need to change that mindset. And we did that by a lot of studies and then providing the information they need to show how important it is. We engage with them every step we take. And we make sure that we have the right people attending the right meeting.
This platform that was created for everyone to come together to look at human resource for health production. So we're able to galvanize support, engage state government, engage the leadership of their training institutes, and then the regulatory bodies.
They bring us together and they try to enlighten both the ministry and us why this should be done and that should be done. So it makes things easier for us accessing the fund that we need for running of the school from the ministry and the state government.
We have had opportunities to sit down with them to plan, and all those things that we plan are actually executed. It has also encouraged the state to do much more than it is doing in terms of addressing issues in this health training institute.
We have done approximately 167 construction works. You see, we also used the construction works and the rehabilitation works as a bargaining chip to get government to commit its own funds into improving the schools.
As a result of the approaches we've taken and the advocacy we've done, we have 16 schools receiving regular monthly funding from the government. It's when we started engaging and raising awareness of the communities on the need for them to produce their own health workers. Before, they were really expecting health workers to come from the city and stay with them. If you cannot produce your own, how do you expect another husband to release his own wife to come and service you? So that was, and that's an eye-opener to many of the communities.
We've been able to mobilize the community to understand the issues and be ready to play roles. This is a program that has aimed right from the beginning to understand the way the community thinks and what they themselves are ready to do to address the issues.
The strategy is built with sustainability in mind right from the beginning. For example, the communities were involved in the selection of who is to represent them. So who are they nominating? The communities contribute substantially to the education of this girl they nominated. Some of them contribute financially, some of them contribute materially. When they visit the city, they visit her. And when she comes back, there is that pride that, look, we produce our own, and then the government are very proud of them.
The key to increasing the number of female health workers is to increase the number of student places, female student places in health training institutions, which is dependent on the accreditation status of the health training institutions.
The school has gained from Women for Health collaboration in terms of assisting us in areas where we have accreditation deficiencies.
For example, the Nursing and Midwifery Council has got some standards for schools of nursing and schools of midwifery to meet when it comes to education in order for them to be able to recruit students. One of the standards is that all schools should have adequate number of tutors. There should be at least one tutor to 10 students. So they must have adequate number of tutors, but not only that, they must have the physical infrastructure in terms of hostel, in terms of the classroom, in terms of teaching and learning equipment must be adequate. But also there's the physical capacity of the school, the leadership, the availability of funds, to run the school. So all these critical standards must be met by the Health Training Institute before the regulatory body will be able to award accreditation. When we started the program, only one health training institution had full accreditation status. We had 5 health training institutions with denied accreditation. Having a denied accreditation meant that they couldn't recruit students. So with Women for Health support to these health training institutions, all the 5 health training institutions have actually regained their accreditation status. Now we have 9 health training institutions with full accreditation status, which means that those health training institutions initially could only recruit 50 students per intake, but now all these 9 health training institutions can increase the number of students that they recruit up to 100 students per intake. One thing to recruit more students, is another thing to ensure that they are retained and they graduate. So improving the quality of teaching is actually very, very critical. Before the Women for Health program, we had a situation where the graduation rate in most of these training institutions was actually very low, sometimes as low as 16%. But then we realized that students were mainly taught passively. Students were not actively involved. I think the key turning point when it comes to quality of teaching is the reorientation of the tutors themselves in terms of the need to actively involve students, the introduction of effective teaching methodology, student-centered learning, for them to be receptive to students asking more questions, student contributing, and then rather than, student being empowered, to be able to ask questions, to be able to actively engage in their own learning.
So we did an audit to try to say, okay, so what are those things or what are those facilities or the laws or the policies within the schools that will enable a woman who wants to study in the health training institution to remain and actually finish and, fly with flying colors. That we got females in management position, females in most of the committees, because then we know that when decisions are made in the school, it will definitely address the needs of the female students. Some of the things included, infrastructure, making sure that while we were trying to build or construct additional facilities for the health training institutions, we thought about the married female hostels, for instance, where it became easy for students who were married and who had babies to remain in school.
It's helped me to speak in public and also express myself, and I used to be confident.
We piloted an innovative e-learning solution in Birnin Kudu. The e-learning solutions provide cheap access to cheap internet and avoids the problem of power cut. It opens up the schools to have access to this modern teaching materials and teaching aids.
Because you do your assignment or test online, immediately there your score is being displayed to you, so you know how to tighten up your belt in exams. But with the e-learning system, you just do your assignment online and submit it online.
They now have access to what's up-to-date materials. They can now communicate with their lecturers 24/7, okay, using the e-learning system. It's really an experience for them, quite amazing.
The student can be in her hostel and tap into the e-learning facility and be able to get information of what she gets or the lectures that she misses.
The electronic learning system has actually been the game changer when it comes to improving the quality of teaching. And not only students, even tutors were actually, they have been empowered. So the capacity of the tutors have been built to be able to produce learning materials to support student learning through the electronic learning system. If we're able to get this right and we're able to expand, sustain this, I think we're looking at improving access of people, either even from rural areas, to be able to access education. You're talking about them being able to access education in a more affordable manner, and then being able to actually actively learn rather than passive learning, which has always been historically, which is the way teaching and learning in Nigeria has always been.
The Foundation Year program looks at young women who are from rural areas that have health facilities that do not have female health workers. If we pick young women from the rural area and help them to gain access into the health training institutions, they are more likely to go back and serve the rural areas. And so the Foundation Year program was born. There are two strands. You have the bridging strand that supports young girls who do not have the required 5 credits. And then we have the preparatory strand that supports those that already have the 5 credits. I can tell you that we have over 1,000 young women now who have gone through the program, and about 65% of them have actually gained admission into professional training to either become nurses, midwives, or health workers. But I want to blow our trumpets. They are performing. They are top of their class.
samu canji da dama na ladabi da biyayya da halayyar tsafta.
Muna kyautata tsammanin in Allah ya da za su ba wa al'umma wannan gari tallafi bangaren abin da ya shafi lafiya, musamman ma mata, 'yan uwansu mata da idan suka kamu da larura kaga za su ba da gudunmawa ta farko kenan kafin a ce a kai ga asibiti.
Ba ni kaɗai ba, da iyali da mutanen gari da sauransu, kowa yana mata murna, yana taya ta murna da fatan alheri.
You know, these girls, once they go back to the community, we think we are really planting an important seed for the whole transformation of the community. And we have so many girls who are the first in the entire community to have gone beyond secondary school. So they are back into the community as role models, and they are always, their advice sought after by other parents who wants to see their girls be in the same position. They are playing the role of champions, mentoring younger ones to become not only health workers, to take any profession they want to have, and importantly also for other parents to see that, yes, my own daughter can make it since the daughter of my neighbor has made it.